Well, hi everyone. Welcome to today's What's New in Addiction social work lecture. I'm Zan Rothenberg, one of the social work stream program directors. Sorry, the microphone's not on. Okay. Oh, maybe I just need to be a little bit closer. I can do that too. Okay. Yeah. I'd like to start by recognizing that we're gathered here on the ancestral territories of the Squamish, Musqueam, and Tsleil-Waututh nations. I'd also like to acknowledge that the fellowship opportunity that has been made possible for Jamin is an incredible partnership with BC Women's Hospital. It's been in honor of Denise Bradshaw, and we're very grateful for that partnership. I'd also like to mention that our social work applications are open and more information is available via the website. We're accepting applications until December 4th. And with that, I have the pleasure of introducing Jamin, who will be presenting on barriers and considerations for providing family-based services in perinatal substance use programs. Jamin has been working as a social worker in the field primarily of housing, homelessness, and addictions. He does not come to this work with lived or living experience with substance use or homelessness, and so he tries to approach it carefully. Jamin began his career as an outreach worker for youth experiencing homelessness in the United States. He moved to Vancouver to complete his master's degree in 2020. Since completing this program, he's been working with Vancouver Coastal Health on the intensive housing outreach program. As an addiction social worker, Jamin hopes to spend the next year expanding his knowledge and skill set and to become a better ally to people who are using substances. I'd also ask that you hold questions until the end and mute your cell phones for those of you in the room. Thank you.
All right. Hi, everyone. As Zan said, my name is Jamin, and I'm one of the Addiction Social Work Fellows with the BC Centre for Substance Use this year. Today, I'll be presenting on barriers and considerations for family-based services and perinatal substance use programs. Before I forget, I'm supposed to mention that periodically the PA system might go off here, and so if that does happen, I'll just pause temporarily and then resume when it's over. I'd like to start by acknowledging the land that I'm joining you all from today. I'm a settler of mixed European ancestry living on the unceded and continually occupied territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Acknowledging this helps ground me in the history and context of where I live and brings awareness to other struggles around the world. Colonization through the means of illegal occupation is an ongoing experiment that continues to threaten the lives of millions of people around the world. Another important acknowledgement that I'd like to make is, as Zan mentioned, is the context which I'm allowed to be here and part of the fellowship this year. My spot as an addictions fellow is funded by PHSA and BC Women's Hospital through a legacy scholarship honoring the life of Denise Bradshaw. I never had the privilege to meet Denise myself, but I've spent time connecting with my sponsorship team and learning about perinatal substance use programs through my time in this fellowship. And I've gotten a sense of the enormous impact that Denise had in this field. Among many things, Denise was a fellow social worker who dedicated over 30 years of her life working in the field of healthcare and substance use services. Denise was directly involved with a number of perinatal substance use programs for the province. Her focus in this work was in shaping programs and systems to promote Indigenous cultural safety, trauma and violence support care, and harm reduction. Denise was awarded the BC Provincial Healthcare Hero Award in 2019 and hoped that her work would continue to inspire others. In acknowledging this award, Denise left us with the following encouragement. We need to accept that we all have a role to play in terms of addressing the stigma associated with substance use and dependence in our society. We can be compassionate, non-judgmental, and respectful. We can listen better to people with lived experience and follow their lead in terms of what services and supports are required to meet their needs. My last acknowledgement, as Anne previously mentioned as well, is that I don't come to this work with lived or living experience with harmful substance use. Because of this, I aim to come into this work humbly, but I always recognize the limitations that this brings to myself. My other identity as a cisgendered male is that I think this positions me further and further away from the population being discussed. And so with that, I ask that I'm not seen as an expert in this topic. Everything I've learned comes from experience that's been given to me by friends and patients and clients in academics. And so as a learning in this area, I welcome any critiques and corrections and ask all of you to support me in my learning as you may see fit. So this presentation has two main learning objectives. The first is to explore relevant literature on family-based care for perinatal substance use programs in both acute and community settings, and then to examine applications for social work practice and larger interdisciplinary teams. The only conflict of interest that I had to declare is that with BC Provincial Health Services Authority and BC Women's Hospital, as I've stated, my position as an addictions fellow is being funded by this provider. And so I'll later be providing information back to the organization about the services that they do provide. So today's agenda, going over it, it'll be providing a bit of background and context to this topic, then reviewing some relevant literature that I sorted through going through it. And then going on to define family-based care and what that looks like for programs and service providers. And then as some additional applications of practice in a community setting, in an acute setting, and then to social work practice specifically. And then finally, in an additional note, just on the language that I'll be using in this presentation, my hope is to be, as we are, this is related to perinatal care, my hope is to be inclusive to any individuals who are pregnant or have given birth who don't identify as being female. But I also want to show my great respect to anybody who does identify with calling themselves a woman or a mother. And so therefore, I use a number of different terms interchangeably throughout this presentation, such as mothers, birthers, parents, people who are pregnant. My goal is to be inclusive of everyone and to acknowledge the wide range of experiences that exist around gender identity and childbirth. So a lot of this work for the presentation has come out of and been influenced by my experiences on the Families in Recovery or FER unit at BC Women's Hospital. FER is an inpatient perinatal substance use program here in Vancouver. And while FER is a very specific program, my hope is that takeaways from this presentation will be applicable to a wide range of settings. As a funder for my position as a fellow, BC Women's has asked me to conduct a project looking at the experiences of patients and their partners' families who have access for and other perinatal substance use services in the province. Most programs are designed to serve mothers and children first, while additional family members are often left out from substance use services and or treatment. And in a way, kind of splitting care for families in this way can cause divisions in substance use and additional parenting goals. And so right now, BC Women's, their teams, they're trying to explore how to better support families as whole family units while still prioritizing care for birthers and children. So the future study that I'll be conducting will involve interviews with patient partners, family members, and community service providers. The goal is to provide feedback to project sponsors about ways to improve their program and expand their scope. So diving in, it's important to acknowledge some of the barriers being faced by pregnant people who use drugs and their families. Pregnancy is a particularly vulnerable time for families. Physically, birthers and their children face a number of health risks, and then any involvement of substances can compound those risks or provide new dimensions of complexity. Mothers and babies each face their own respective health risks depending on the amount and frequency of substances being used. And then parents and birthers in this age often face a lot of social pressure as service providers and community members may often be quick to report any parental substance use that they see, even outside of any harms that they observe. Simply the presence of substances being involved triggers a lot of awareness and concern from people at a time. Because of this, substance use places parents at a higher place of social surveillance and stigma. And beyond all of this, the presence of any economic, housing, social, or political challenges can only further exacerbate and compound the risks and barriers that families may face. So diving in, how big is the population that we're talking about here in BC? This chart shows recent statistics from BC's Perinatal Health Report showing the annual number of births in the province. It shows that birth rates have maintained fairly steady with a slight decline over the last 5 years. Total number around 41,000 births in the last year documented. Broken down by the number of deliveries by provincial health authority, Fraser Health continues to see the highest number of births, was about 42% of all total births in the province. That's followed by Vancouver Coastal Health with 22%, and then Interior Health with 15%. This chart also shows that those rates have stayed relatively similar over the last 5 years. These are recent statistics from perinatal services in BC showing rates of substance use during pregnancy over the past 5 years. You'll notice a shift kind of in 2018 when the other drug use category became the most common and has been on an upward trajectory since then. Other drug use counts for cannabis, prescription drug use, and all other illicit substances. The increase is likely due to the prevalence of fentanyl in communities. And finally, these are the most recent stats from the BC Coroner's report showing unregulated drug deaths by sex over the past 10 years. The graph shows that women make up approximately 22% of all deaths. And then among those, they've kind of designated a few populations who are overrepresented and are a very high risk. Those mainly being people involved with criminal justice, people experiencing homelessness, and then the perinatal population as a very high risk population here. And then unfortunately, there isn't a graph for this, but Indigenous women are also at a higher disproportionate risk of the ongoing effects of drug toxicity, most likely due to systemic barriers, accessing services, or fear of racism or stigma. First Nations people died from an overdose at roughly 5 times rates higher than other BC residents. So moving on to the review of relevant literature, in wanting to explore how substance use programs could expand services for family-based care, the body of literature that existed was quite small, and so I kind of had to pull from a few different areas, mainly being child welfare, perinatal substance use services, and then engagement for male-specific populations, kind of around the topic of intimate partner violence. When I began researching this topic, I found that child welfare practices seem to be the furthest ahead in thinking about family-focused care, so I decided to start here. I do want to be very careful in I'm not trying in any way to infer that parents who use drugs are more likely to be involved with welfare services. In fact, there's no conclusive evidence to even suggest that. I chose to draw from child welfare literature because I found that they had a large body of literature exploring family dynamics and wraparound services and how to navigate those with a combined family unit. Obviously, child welfare is, working or hoping to focus on family unity, and so that is a big piece of this. In the late 1980s, the theory systems of care started being used among child welfare services. This was described as a coordinated network of services and supports designed to meet the multiple needs of children and families and to explore the systems of care model. Williamson and Gray in 2011 conducted this study to look at how this model had been implemented over the previous 30 years. For the study, they interviewed about 44 participants in child welfare services, both staff and clients and client family members, about their experiences with family involvement of welfare. Through these interviews, they found often what was seen as like a disconnect between a program's stated intentions and what people actually experience. While the program stated a goal of being focused on families and kind of serving and supporting a family unit as a whole, families felt that they were instead kind of split up and treated as individual entities. They attribute this to a number of ongoing systematic concerns, though, such as lack of training and high rates of turnover among service providers, challenges collaborating with community partners across different service sectors, as well as any ethical concerns among service providers in navigating challenging family dynamics. Two of their main conclusions and recommendations that were that the true collaboration of families require more than just letting families sit at the table, but really families need to be a part of planning and implementing care and achieving goals. It was also recommended that social services try to develop consistent tools and frameworks for supporting families throughout their systems of care. For me, this study highlighted the specific methods used by welfare workers to integrate families into practice, showing that it is complex and it does vary in a lot of ways. It's also important to note that this substance use in any family context can bring new dimensions of complexity, and that wasn't addressed in this work. Over the years, a group of tools known as family group decision-making has also started to gain prevalence in child welfare practices. Family group decision-making is sort of an umbrella term looking at a series of facilitated meetings designed to provide a forum for family and service providers to come together, develop a plan, and work towards it in terms of protecting a child. So these kind of meetings were meant to be facilitated by a facilitator, as well as peers or facilitators or additional community advocates could all be present for it. The goal is to build trusting relationships with families, identifying ongoing strengths, and then create an environment for a family to set their own goals and work towards achieving that. Korea and Brazil in this study in 2009 conducted a review at the effectiveness of these programs, looking at how to reduce child welfare involvement for different families. In the end, they looked at 16 different empirical studies around the world that explored the decision-making, specifically in the context of a child welfare setting. They attribute the prevalence of these practices to a larger cultural shift driven by families and wanting to be more involved in their care rather than letting service providers to sort of tell them what to do. When it came to patient feedback from these programs, families reported positive experiences and satisfaction with the programs, and staff also provided the same feedback. However, when looking at the results of them, unfortunately, the results were a bit more inconclusive. The researchers found that it was difficult to measure the efficacy or outcomes of these programs. It was hard to tell if these programs had any impact on, reported safety of families, increased stability, or even long-term referrals to services. But they attribute a lot of this just to more methodological problems such as small sample sizes, inconsistent practices, unclear measurements for outcomes, and the no control or comparison group. So the main takeaways that they had was that there is a lot of evidence and support for family-based care. And this was seen in the prevalence of programs using the family group decision-making tool around the world. However, the reader was kind of encouraged to be careful and specific in designing programs around this. The researchers state, from our review of the literature, we believe there is a reason for cautious optimism, yet more research is required, particularly studies that are more able to connect outcomes with clearly specified processes and evidences of implementation. They described a risk for programs who state that they might be family-based in practice, but really aren't. And so, by not fulfilling that practice for families it risks weakening engagement with them, and then just like inconsistent long-term program outcomes. And so in the end, they concluded that there was a need for further research. A similar conclusion was later brought on by McGinn et al. In 2020. In their study of 18 additional international programs where family group decision-making tools were utilized, the authors found that in the majority of cases, there wasn't firm evidence supporting the effectiveness of these practices for reducing cases of child maltreatment or abuse. However, their main takeaway in this was not to discredit these tools in any way, because they felt that, or what they found was that families and service providers had overwhelmingly positive experiences with them. It just seemed to be more methodological concerns in how these studies were enacted that didn't result in quite the outcomes that they would have hoped to see with them. The authors gave a strong recognition to the increasing complexity of child welfare work, explaining that it's challenging to kind of change the ongoing tide of abuse if it's present or neglect, as well as any outside external factors such as poverty, housing, family histories of trauma, and so on. They also point to a lot of systemic factors affecting child welfare practices, such as heavy caseloads, ethical dilemmas, and a lack of any other effective community supports. So they conclude that there's a need for further research in this area, but if organizational leaders and policymakers want to explore implementing more family-based services in their own context, they need to widen their lens and include any other sectors beyond just child welfare. Another important part of this conversation in Canada and British Columbia is the high representation of Indigenous families in child welfare. Indigenous children are overrepresented in child welfare services. 2021 data showed that roughly 53% of children in the Canadian foster care system were Indigenous, despite making up 7% of the population. Hayton et al. In 2018 conducted a scoping study reviewing peer-reviewed empirical studies directly related to the involvement of Indigenous families with child welfare services between 2000 and 2017. This was mostly in an American context, but there were a number of studies that took place in Canada. Again, they found similar experiences where children with welfare services had experiences with providers where they were seen as adversarial, punitive, shame-based, and racially biased. And the researchers went on to describe that experiences with the system can compound challenges that are already faced. Popular ideology that was present in the literature was this 7 generations philosophy, looking at the need for First Nations who might need 7 generations to fully heal from the destructive effects of colonization and genocide that has been forced upon them. This is acknowledging that the decisions today affect the generations in the future. Another prevalent theme that came up in the literature was the idea of the long emergency, which is seen as a term that's mainly been coined by climate scientists in recent years, looking at the long-standing effects of any tragedy on a community. So viewing this in kind of child welfare in Canada with a historical context, the authors called this its own sort of long emergency, as current disparities have been manifested over years of harmful practices and policies that stripped away social resources, and Indigenous families in Canada. So in the end, Heat and All found that programs working with Indigenous families who saw the most positive outcomes were the ones who were Indigenous-led and who made a specific focus to provide culturally safe care. The researchers recommended supporting policies and programs that allow Indigenous communities and organizations to have greater autonomy in working to heal their own communities. They point this is especially important for supporting a population like Indigenous mothers and birthers, and also to be innovative with the types of programs that are being created, because it isn't just enough to sort of copy and paste the same programs that have been used, but to really create new programs to support Indigenous communities in new ways. This is another study by Robertson, Sinclair, and Hatala in 2022. This was an Indigenous research project from Manitoba, where the research interviewed 12 Indigenous mothers involved with child welfare services in the province. This found also similar results to previous articles found, mainly that participants had overwhelmingly negative experiences with welfare services. Families often felt unsafe and unheard. And so some of the feedback that the mothers who were interviewed for the study provided was that they wanted to place a strong emphasis on prevention, even working with families even before there was any involvement with child welfare. And so a lot of this would look like education, role modeling, mentorship, and then additional financial assistance. So this kind of brings us to the main intersection, which is bridging the fields of child welfare and substance use services, and kind of what we can take from one and apply to the other. In this article from 2014, Blakey conducted 24 interviews with service providers from both healthcare and welfare services in BC, kind of looking at, between these two sectors, how did workers work with each other, what worked well, and then what barriers were there for collaborating with each other. A lot of the barriers they found was that there was high staff turnover, which disrupted patient care plans. There was also a lot of difficulty maintaining open lines of communication, as well as long wait times to access services. Ultimately, these barriers limited collaboration and affected families and resulted in a lot of poor outcomes for them. As far as potential solutions that service providers brought forth, the main ones centered around building collaboration and then expanding interdisciplinary care on teams. They provide a few recommendations for increasing interdisciplinary care by reducing barriers and increasing services to other teams. And they are also require further education for all staff who are involved with families. I also want to highlight the prevalence and importance of harm reduction principles that were brought up by kind of both welfare and healthcare services in this. Providers from each field commented on the positive impact on harm reduction principles, feeling that it can make a positive influence for families. They said that they kind of saw this as a key opportunity was by bringing in the harm reduction philosophy, was that it would shift the focus on the gaze from parental substance use to really what are the determinants affecting a mother or a child's health. Looking at not just substance use, but also housing, social isolation, food security, and any exposure to violence. So some of the key takeaways for me with this study were, one, the focus on interdisciplinary care and the strength that can bring for a team and for a population that's being served. Another focus is on different social determinants of health and kind of moving beyond just focusing on substance use and the prevalence of that to what are the factors, both external, social, that are impacting any family, and how are they harming them. And then there's a large emphasis on understanding the idea of family-centered care in this. And there was a brief mention of fathers, but really that was kind of left out from the focus of this. So I'm going to jump back in time a little bit to highlight this document to add a bit more context to the history of this topic, specifically around family-centered care. This is one of the earliest documents I reviewed looking at family-centered substance use care, and it was put forward by the Substance Abuse and Mental Health Services Administration organization in the United States. SAMHSA is an American federal organization, and at the time in 2007, they were looking at funding new programs who would kind of implement this what this time was like an emerging service approach. And the goal is to address the needs of pregnant and parenting women with substance use disorders, as well as adolescents, as well as their families as an extension of the family. The document was written in an attempt to try and understand the complex web of intersecting socio-political cultural factors that can affect someone's journey to and in the experience of an addiction. And they kind of base it off the assumption that if one person in a family is experiencing harmful effects of substance use, then that is something that affects everybody. And so therefore, to support that family, it's not just enough to support one person, but really to try and support the family as whole where needed. In the end, this document provided a number of recommendations or principles for what family-centered care could look like. It's important to note that a lot of this still comes from a place of prioritizing care for women and their needs, women or birthers. And that I think that's something that can't be lost in a lot of this program design. It's also important to note the idea of women defining their own families, and that families are kind of a fluid idea that isn't just based around biology, but that it can shift based on experiences and cultural background. I think in this day and age, like a type of program that is designed around this might not seem as novel or as new, but I think it's helpful to kind of show like where things were, back in 2007 and kind of how they were looking towards the future. And then also comparing this with what we do see today and where there might be some differences. So kind of trying to put this into practice, I wanted to highlight a few more programs where families-based care specifically for pregnant and newly parenting families came into play. This first report by Chonal reviewed and interviewed a series of mothers about their experiences of mothering while completing substance use treatment programs in the United States. In each of these cases, mothers were taking part in a 3-week substance use residential treatment program with their children. So they were allowed to be parented, they're allowed to be parenting, and there was appropriate childcare available as mothers were completing this program. Upon review of the program outcomes, Chonal found that the mothers overall had positive outcomes. They saw more success upon completing these programs. Substance use went down. And mothers reported that they were able to continue their role as a parent during this time, and that this was a really crucial factor to completing this treatment. Chonal described the importance and benefit of providing services that meet clients in their context as a parent, rather than taking them out of that context to seek treatment where they can then be deemed able to parent. Some other key takeaways from this were that, as I mentioned, children were a main motivator for parents, and so having children with them was a main motivator for mothers and birthers accessing and completing treatment. For me, this raised the question about the possibility or the importance of having available childcare around any substance use services or community programming. And then also raises an important question about the importance of access to assistance for mothers. In the reviews of the study, they talked about the importance of assisting parents who are kind of going through these early stages of parenting, and the necessity of having access to available supports while they were completing available programming. Overall, there were a lot of limitations with the study in the end, though. There was a small sample size. There was no control group to compare it with. It's also important to note that the program involved extensive access to multiple forms of clinical treatment, which would influence positive outcomes of the program. And then there's also a stated focus on families with this, which mainly meant that for this study, it mainly meant mothers and their children. There wasn't much mention of involving husbands or partners in the programming or additional family members. A similar program that I looked at was this study by Perinatal in 2022. They conducted a review of the maternal initiative reflecting recovery-oriented residential services, or the MIRRORS program. This is a grant program also funded by SAMHSA, as previously mentioned, to support substance use treatment for women with minor children and non-residential family members. And so this was the first study that I was able to find that did have an added focus of supporting partners, specifically husbands and fathers. The study included 215 pregnant and postpartum women and their minor children and their families in Houston. And they extended services to additional family members as needed. Overall, the program also saw positive results. There was positive feedback from counseling, specifically the opportunities that were there for male partners. In the end, the program saw positive results from parenting classes as well as play therapy. Participants reported that having children with them or being able to visit was essentially for their own recovery, whatever that may look like. Because of this study in my own project, I was curious about how the study's results, what it looked like for specifically having partners and husbands involved with this process. And so according to the study, participants felt positive experiences having partners or fathers involved with children and taking part in the available program. There's a desire to have them be a part of that. And so they appreciated the opportunity to do so. Helping promote healthier and shared parenting helps build mutual understanding around addictions in either parent, and participants appreciated that. And in the end, almost all program participants stayed active in the program, as about 90%, 97% stayed active for the full 30 days. Rates of employment increased, rates of homelessness decreased, and overall reported substance use also decreased among the participants. Again, important to note the limitations of a study like this. I think the most glaring one is that there wasn't any use of urine drug screens at all, and so any reports of substance use was just voluntary information given through a survey, and that only happened at intake, discharge, and then a later follow-up a few months later. The services under review also seem to prioritize abstinence-based treatment. In fact, most of the programs from the literature did. And there was very little mention of harm reduction, and participants either reported a yes or no whether they had used any substances previously. The last study that I want to highlight was by Hinton et al. In 2019, looking at the family-based recovery program, FBR. This worked at combining substance use treatment, specifically with attachment-focused therapy. This was described as an in-home treatment model for parents who are using substances who have children under the age of 36 months. Families were supported by a team of 3 specialists, 2 clinicians, and 1 child services worker, and they were able to meet clients in their homes. Kind of the main goals or the main tenets of this program were that, 1, parents can achieve recovery in absence while still actively parenting, and that bonding with the child, bonding with the child is a big part of reinforcing abstinence or decreased substance use for families. So over the years, the 10 years that this program operated, they had 11 teams that serviced about 1,400 families. In the end, about 85% of families included a maternal caregiver only, 10% included 2 parents, and 5% included a male parent only. So just kind of give a breakdown of what these family structures look like when we were talking about the parent structures. The main takeaways that I found reading through this was that overall, the program found decreased substance use among parents. There was 38% negative screenings in the first week, and then 66% in the 20th week. There was decreased overall parent distress, and parents reported less depressive symptoms. There was 93% of cases stayed active in the program for longer than a month, and then 81% of discharges had children living with at least 1 biological parent, which was a stated program goal. And they also found that there were stronger partnerships that were developed between child services and substance use services, and there was a lot of opportunities for parents to kind of be involved with their decision-making and program care. Some of the limitations of this study are as follows. The program implemented, again, some harm reduction principles in that they acknowledge that there is benefits in, some decreased substance use, even if it wasn't abstinence. However, the program still did prioritize abstinence as the main goal. There also was limited data analysis on outcomes, a limited scope as well, because kind of their main focus was specifically around the factor of child removal. And so in the end, they just recommended that there be a further need for research in this area. And I think another limitation of this is that there wasn't any mention specifically of queer or non-binary parents. It was mainly based around this heteronormative model of one male parent and 1 female parent. Some of the main takeaways for me from reading through this, though, was that I was intrigued by a program model that provided in-home community services. I think this showed that this can happen and can happen well in a community setting. The program is also purposely open in its scope in that it was designed to address a lack of programming that was specific for fathers. And so while the majority of cases did end up still being a female-only parenting household, I think it's important to note that about 50% of the households who participated in this program did have at least the presence of 1 male parent. As a practice note, I wanted to just point out 3 evidence-based programs that came out in the last few articles. Practitioners reported the use of these programs and really positive results with them. First would be Seeking Safety. Kind of in short, is a cognitive behavioral therapy that is shown to be effective in treating PTSD. Second was the Celebrating Families program. This is kind of a well-established program working with parents in early recovery and their children. And the focus is on helping families who have challenges with substance use, work to help kind of unify them. And then the third is just the emphasis and importance of motivational interviewing. This is a style of engagement, shaping conversations to build trust and spark ideas towards activating change in a person's life. The last program that I wanted to highlight, though, was the Fathers for Change program. And this was a pilot program that kind of started in 2015. As I previously stated, the body of literature around family-based care was so small, and so intervention specifically geared towards partners or husbands was even less. Any programs that were geared towards fathers or men was specifically around any case related to intimate partner violence or a batterer intervention program. And so the Fathers for Change program was slightly different from a lot of these because it had a heavy emphasis on substance use, personal behavior, and then changing family dynamics. In their report evaluating this pilot program, they found that intimate partner violence was prevalent amongst families where there's a history of substance use. And the Fathers for Change program was created to support pregnant and parenting mothers or birthers by intervening with parents, specifically fathers in abusive relationships. So the pilot program, when it was started in 2015, supported a total of 19 male participants with children under 10 years. All of them had a history of physical violence towards their partners and co-occurring substance use. The program had 4 main goals, which were cessation of violence and aggression, abstinence from substances, improved co-parenting, and increasing positive parenting behaviors. In the end, the program also found overwhelmingly positive results. They saw decreased rates of substance use among male participants. About 90% remained abstinent for the full form of the program. Feedback from program participants was that having children with them or having access to them was a primary motivation for their change. And while not all fathers were able to have joint sessions with a partner in the end, the ones who did reported overwhelmingly positive experiences with that. And they felt that it brought a sense of unity to them and their families, having this opportunity to meet with a clinician, with their partner, to work through any past behavior. There are obviously some limitations to the study that must be accounted for. One is a small sample size, and it mostly focused on heteronormative couples. So the study also exclusively focused on couples where intimate partner violence was present. And this is not obviously the case for all couples, especially even if there is a context of substance use. The study also prioritized, again, an abstinence mainly approach, or prioritized that, and had no mention of harm reduction. Because of this, I do have doubts of how it could be applied in a lot of other community settings, but I still think the findings were valuable. So some of the main takeaways for me were just that high need for partner-specific interventions, specific strategies for addressing harmful behaviors related to aggression and substance use, the focus on building parenting and co-parenting skills among participants, and then the goal is successfully unifying partners in their own treatment goals. So summarize some of the takeaways from the literature I pointed out so far. I think I'll be repeating some of the points I've already made, but across acute and community care settings, there is a lack of family-based programming that can meet the needs of women, children, and partners or family members who might all be affected by substance use. In most cases, the substance use programs under review promoted abstinence from substances and took place in an American context. I think what felt unexplored was the effectiveness of implementing a harm reduction approach. There's very little speaking to fathers and partners about their experiences adjacent to a wife, girlfriend, partner who is pregnant or newly parenting. I think it's interesting to note that all the programs who expressed wanting to be family based, it shows that there was an intention of that. There was a goal, kind of a hope to be focused on families, but in most cases that just focused on like the mother, birther, or the child. And I think there's also a further limitation here around queer and non-binary parents accessing perinatal substance use services. There's next to no literature or even acknowledgement of that in a lot of the literature reviewed. So moving on, I'm just going to explore a few more gray documents that I think summarize a lot of this finding for provincial programs here. So one key document that was developed by our provincial government was Families at the Center. This document came out of a task force created in 2010. The goal is to help guide transformation for BC systems to achieve better results for families affected by mental health and substance use concerns. I found this to be one of the more concise documents documenting what this framework could look like if implemented throughout substance use services in BC. This obviously isn't just focusing on perinatal substance use, but I think it does apply to a lot of that. In this document, they affirm, again, a growing up body of evidence supporting various family-based interventions. They agree that programs are shown to reduce symptoms of substance use disorders and mental health disorders when there is an involvement of multiple family members. An effective support for, this is seen as an effective support for any children whose parents might be experiencing a mental health or substance use disorder. And the Families at the Center document also points out how, in child welfare, any family-based service is kind of seen as best practice. And so it would seemed to make sense that this also can apply to adult mental health or substance use services, specifically in the context of a family. The Families of the Center document put together this tool, which gives a spectrum for what family-based services could look like. It addresses how families are engaged with, how systems are held accountable, and focuses on how families might experience different programs. I think tools like this are helpful for visualizing change and kind of looking at where you are and looking at where you might want to be. It also provides, a bit of a roadmap of how to get there and kind of, provide some examples along the way. I think it's also important to note that this doesn't have to be an all or nothing approach. It's not one simple move to become a family-based service, but really it's something that can happen over time. It can be fluid, and change can happen slowly. Another notable document was the Provincial Perinatal Substance Use Program's 2021 Blueprint for a Perinatal Substance Use Continuum of Care. This was the result of about 3 years by Perinatal Services BC, as well as BC Women's Hospital, with about 300 other stakeholders involved. And the result from this was a guiding document that was kind of set to provide the vision and framework for perinatal substance use services in British Columbia. The document touched on a lot of things, but one of the main ones was, again, just the prevalence of trying to increase full wraparound care for families. In this, they create this document, a visual looking at what some of those guiding principles are, as well as the key components of them. On the top, you'll see, a number being recovery oriented, wanting services to be accessible, also making sure that families are inclusive. And then at the bottom, thinking about what are the key components of the programs that they're envisioning. A lot of them were centered around housing and making sure that families who are accessing perinatal substance use services in the province would have access to an array of housing that would service, not just a single parent with a single child, but also, multifamily and multi-generational. And the goal is that it could be an array of options. Another part of this application to our current setting is the essential need for programs to better support and empower Indigenous families. This includes providing resources, services, and opportunities to address unique cultural, social, and economic needs. The historic context of forced family separation within Indigenous communities is deeply rooted in systemic injustice and state-sponsored violence. Policies and practices such as the residential school system and the 60 scoop and the 90 scoop in Canada forcibly removed Indigenous children from their families, and that's a traumatic intergenerational impacts. So with much of this forced generation still happening today, programs and their staff need to ensure that they're working to remove barriers to allow families to stay unified through this. And then the last document that I wanted to highlight just quickly before I move on to the applications was a literature review that was conducted specifically for the Provincial Perinatal Substance Use Program at BC Women's. In this, they also looked at a number of programs throughout the United States that had focused on family-based care, and they came to the following conclusions about what these programs could look like in order to achieve best results. And a lot of it focused on breaking down silos, again, between families, seeing them and addressing them as a whole unit, and then creating services around them that can serve a family in that way. This quote just reads that providing family-based recovery programming entails a whole of family approach, entails taking a whole of family approach to assess and address the needs of pregnant and parenting women, their children, partners, and other relevant family members. Providing such a wide range of services requires collaboration and coordination across service delivery systems to focus on the context in which families reside. And then I think another important note is just the prevalence or possibility of intimate partner violence. This is something that does seem to come up as a concern mainly for service providers. I think a lot of that is reflective of this being something that was often ignored by service providers in the past. And really a lot of our system has kind of looked at intimate partner violence as trying to separate whether this is something from substance use, violence and aggression, or child maltreatment. But a lot of the evidence that was reviewed for this looked at ways to incorporate this together, seeing the interplaying complex dynamics within families and trying to treat them as so. I think this is definitely not something to take lightly, and I don't want to gloss over this in any way. I think I can personally speak to the complexity of trying to deal with a family where there is ongoing challenges and risks of physical, emotional, and or psychological abuse, And so therefore, it is something that does need to be taken seriously and teams need to have sensitivity towards. But at the same time, we can't assume that or expect that this is something that is going to happen in every relationship. So in summary of looking at family-based care, a lot of this is ensuring that women stay at the center to inform who their families are. Relationships must be maintained and supported to ensure strong family structures. Trauma-informed care is crucial, as many perinatal substance use programs support populations who have experienced complex trauma. There's a need to acknowledge that family systems change constantly over time, and family can often be a fluid idea. And then there's expanding programs and their scope to make sure that they're able to work across service sectors and that services need to be flexible. So moving on to some of the discussion about how family-based care can look in different care settings, I wanted to start with the acute setting. One of the first things that is recommended for teams working in an acute setting is to re-examine how programs or policies, guidelines that specifically address patient families, looking at what exists and how they might be able to be changed or adapted upon. This could be looking at, how is a partner or husband allowed to be involved with programming, and what could change in the future. Remembering that family isn't confined to just a romantic partner or even a biological relation, but really whoever a patient may identify as their closest care circle. A lot of this, when I think about this too, it kind of referring back to the spectrum of family-based programming and kind of asking, how could your program advance family engagement in new ways and sort of move along that spectrum? Expanding program kind of ideas for this is offering education and assessments for families when applicable, making this part of intake and discharge. At all times for any family that you're engaging with is looking at, how can you expand services for them, whether it is expanding food services, visiting hours, or providing full services in regular programming, access to counseling. What would it look like to expand that care for families? And linking a lot of this as well back to the literature around harm reduction and supporting for healthcare services to explore the ways that harm reduction principles are built into your own policies and practices. I won't spend too much time on these, but I did just want to place these in the slide notes for people to come back to in the future. These are two documents that I found really helpful in talking about, harm reduction in the context of pregnancy and perinatal care. And both of these documents informed a lot of the research that has gone on for this program. Applications in a community setting are obviously much different than acute or hospital setting because families are often back in their own community and contexts where they may either have an abundance of family and supports to rely on or a complete lack of them. And so family-based care in a community setting provides a strong emphasis on integrating families into their local communities and providing a range of support services beyond just medical treatment. The benefits of support groups came up a lot in this research, and so there's a lot of evidence for the effectiveness of different community settings and program examples, for putting on support groups specifically for fathers or partners or families as a whole. This also extends just beyond clinical support and looking at how are we supporting partners in terms of social supports, like employment, housing, or food security, and the Fathers for Change program being a good example of that. When you're thinking about examining program policies, to me, this comes to thinking about the context of healthcare and our housing, looking at how programs will continue to support families in the community and how they often have an opportunity to examine their own policies, looking at the ways that, are we not just housing mothers and brothers or children, but also how are their partners or their families able to access those same housing services. Services also need to be longitudinal and flexible. We need to prioritize programs that can meet families in their context and maintain relationships over a long time. Outreach is a necessary part of this, and really programs need to be able to establish relationships. That does take time, and then work with families as they do extend through multiple stages of early parenting. And then community integration. A lot of this does just come back to navigating services, which can be so complex. And so for new parents or pregnant parents who might be interacting with a range of services, it can be difficult to know how, where to start and how to navigate them. This was taken from PPSUB's blueprint for a perinatal continuum of care and addresses a lot of the realms and sectors that pregnant parenting women encounter and kind of shows the complexity of a lot of it. Finally, I wanted to just draw some specific connections to social work practice. Wanted to highlight the role that social workers often play in providing family-based substance use care. Social workers are often in roles of child welfare or healthcare that involve supporting families in complex ways. Social workers are often well-versed in understanding family systems and completing comprehensive assessments. At the same time, though, social workers have a long history of enacting a lot of harm on families. And so that has been done through the channels of welfare and social services, or welfare and healthcare services. So therefore, it's our responsibility to reflect on our own involvement in this. Some tools that I found that can be helpful in working with families are genograms, ecomaps, and family assessments. Genograms are tools often used in family therapy, which provides a bit of a visual representation for family dynamics. Ecomaps are an older visualizing tool that kind of place, how does a person interact with their social environment, not just family members, but also, their lived environment. I think, these can be helpful in just recognizing that nobody is separate from their environment, but we're all interconnected in many ways. Empowerment and advocacy is also a big part of social work scope. There's a big need for supporting families as they navigate complex systems, providing accurate and informed advice to families, and knowing, how to move forward, how to navigate welfare services is a key part of this. Often there's so much community work with being connected to many services, it can feel like there's a loss of control. And so I think there's a need to come alongside families and ensure that they feel like they're informed, that they know what is happening, to know where they want to go and achieve their own goals. Cross-sector and collaboration is also a key part of this. And I think it's pretty self-explanatory. I feel like I've spoken to this, but I think I would just add that it also happens on an interpersonal level, both kind of on the service provider frontline level, but also on a systemic organizational level. That being an encouragement for organizational leaders or program designers to look at, what are the ways that your organization is able to collaborate with other organizations across sectors, and what barriers are keeping you from working well together. And then there's obviously a need for cultural safety and trauma-informed care in social work practice. Social workers need to be trained to be culturally safe and sensitive to diverse backgrounds of families they serve. They need to respect and incorporate cultural beliefs and practices into their interventions, and work to connect families to more appropriate services when applicable. Working from a trauma-informed perspective, social workers can aim to approach families safely, just recognizing the potential impact of past trauma and substance use and family dynamics. So in summary, family-based substance use requires taking a whole family approach to address and assess the needs of pregnant and parenting women. This is a non-specific model with specific expectations. And a lot of this is inspired by multiple service sectors that exist along a continuum. And finally, successful programs are advised to be culturally safe, trauma-informed, interdisciplinary, and cross-sectoral. Thank you, everybody. That is it for now, and I think we'll open it up for questions. And then also, if I may, so I will include my email on the slides, but also any feedback on this would be greatly appreciated. And so this is a link to the survey that you can provide your feedback. Sam, do you want to go for some questions?
Well, thank you, Jamin. That was wonderful. Lots of things to think about there. I think if anybody who has questions can just put it into the chat, that would be wonderful. And I see a few questions kind of coming in. Excellent. In the meantime, I have a question for you. So for communities who don't currently have services for this population, it's hard to hear you. Sure. What recommendations would you make to start? So what would you kind of distinguish as core services versus things that might be a little bit more supplementary?
Mm-hmm. Yeah, that's a great question. I think one of the core services that should be focused on for any community is just having spaces for people to come together, and a lot of that looks like support groups. And so that isn't something that needs to be facilitated by any professional. That is just something that people can gather with they can come together around like a shared experience with a shared goal and support each other. And I think out of that often comes opportunities for mutual aid and support in the community setting. So I think like that, support groups and spaces for people to meet is one of the most essential places to gather. Apart from that, I think, yeah, there's an additional need for translating knowledge to navigate systems. And so pulling in any experts who can kind of speak to whether it is healthcare, whether it is welfare services, whether it is, income and kind of like those services, making connections with those types of people in the community who can kind of provide that additional informed consent and information is a key part of this. Yeah, I would say those things mainly.
Yeah, fantastic. Thank you. Does anyone in the room have questions?
Yeah, the Shutterstock survey, was that BC or elsewhere?
Pardon?
The shutters.
Shutterstock, it's actually it's only a few slides back. Empowerment and power, blah, 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 blah. Shutterstock was the author, I think.
Sorry, I think it was just a stock image.
It's just what?
It was just a stock image.
Stock image. Okay, I see.
Oh, yeah, sorry. Yeah, that was just citing the image that was used. No, sorry.
Okay.
I guess I'm curious as well if in your review of the literature, you came across any services for pregnant women or new moms who are using substances and experiencing homelessness, because that's often a population that are kind of hiding in the community. And if so, were there any recommendations for how to engage that population?
Mm-hmm. So of the documents that I did review and present today, none of them were specific to populations experiencing homelessness, but a lot of them did mention it as being like an experience that was common in the population that they were working with. And so I think like that itself is not a specific intervention that was addressed, but it was a prevalence in it. And so there was just a hope, kind of a recognition that like, these were programs that were needed, that they needed to be more accessible. And the other thing, I guess, as I was looking specifically into the context of housing and housing programs, unfortunately, I didn't get too far into this, and so that wasn't a big part of this presentation. But obviously, when you're talking about housing or the lack of it for families, there is a goal. There's a need that these are services that are accessible with that hopefully the wait times aren't too quick to get into. And so for that, a lot of it was focused around accessibility, coming at it from a housing first approach, just making sure that families who are in need are able to access housing kind of on a quick basis if possible, and that any additional services would come after that and not kind of using those as the means to get into housing.
That makes sense. Yeah.
Is that clear?
Yeah. Yes.
Jamin, are you attached to a program at BC Children's at this time?
Not at this time. I did just complete a few weeks placement with the Families in Recovery Refer Unit at BC Women's, and so since they, them as the funder and like that, them as the funder for my spot as a fellow, they wanted me to complete a placement with them, but also with a few other perinatal substance use programs, and so that part has been completed, but there'll be like more placements along the way.
So from your research, can you see the other things that you think are going well at FER, what FER is doing to try to support this population? Yeah, absolutely. From what I could tell based on my time there, I think their social work team is really has done an excellent job trying to be cross-sectoral. It seems like they do have good relationships with child welfare services. And so I was impressed with that. I think like there was also a lot of careful attention to care planning and making sure that those are meetings that are regular, where everybody's involved. There were invitations for family members or like partners to be a part of that. And so I think like those are definitely some strengths. Feedback or like I think areas for growth is that like their name, Families in Recovery, is obviously like a stated focus and a goal of what they're working towards. But feedback again from patients and staff alike have felt that their program isn't fully equipped to meet families as a full unit. Because part of that is kind of seen like in meal programs specifically, just in like those maybe not being available for a full family. But even rules around there's like visiting hours or curfews for partners, and kind of just complexity around having partners on the ward, but also complications that can bring for families in not wanting to add a program or they will be separated from a partner. Does that answer your question?
Okay. Any last comments or questions before we wrap things up? Yeah. Well, thank you. Thank you again, Jamin.
Yeah, thank you all for being here.